Welcome to Allied Support UK and our Introduction to the Boston Bracing System online continuation education programme. We hope that during the next 40 to 45 minutes you will find information that will provide you with an understanding of the Boston Brace system and its place in the orthotic management of idiopathic scoliosis. We will start with a review of the history and evolution of the Boston Brace system, identify its principles, review the variants of the Boston Brace system commonly used, look at the clinical evaluation process and brace manufacture, look at brace checkout, and finally discuss the evidence that validates the use of the Boston Brace system in clinical orthotic practice. The Boston Brace system has evolved from a concept in 1972 between Ben Miller, CPO, and Dr. John Hall. The Boston Brace system provides a repeatable set of procedures that, when used, help and maintain the balance of the spine and reduce a curve to as neutral a position as possible. This is achieved by symmetric prefabricated modules, brace blueprint, a symmetrical way of analysing the curve and determining and placing appropriate vector forces, specific construction process, and a team approach, each member with their individual expertise, each overlapping slightly with each other, all focused on the patient's success. There are three general classifications of scoliosis. Congenital scoliosis is a sideways curvature of the spine that babies are born with and occurs when the vertebrae do not form normally before the child is born. Neuromuscular scoliosis is associated with disorders of the nerve or muscular systems, such as cerebral palsy, spina bifida, and spinal cord injury. Idiopathic scoliosis is the most common type of scoliosis. It tends to run in families and affects girls 8 times as often as it affects boys. The Boston Brace system is only used in the management of idiopathic scoliosis. The cause of idiopathic scoliosis is likely to be varied, representing alterations in skeletal growth, neuromuscular imbalances, disturbances involving communication between the brain and spine, and others. Idiopathic scoliosis requires X-ray confirmation of the abnormal lateral curvature and spinal rotation of greater than 10 degrees, as well as ruling out other possible causes for the deformity, such as Sherman's disease, juvenile disc disorder, or ankylosing spondylitis. The curve is measured by the Cobb method and is diagnosed in terms of severity by the number of degrees. The Scoliosis Research Society classifications for scoliosis are infantile scoliosis presenting from birth through to age 2, juvenile scoliosis presenting from age 3 through to 10, and adolescent scoliosis presenting from 11 through till 17. Traditional classification shows that infantile idiopathic scoliosis is more prominent in males and females, with a higher incidence of left curve than right. Often associated with other deformities, most resolve spontaneously. Juvenile idiopathic scoliosis is equal in its incidence between male and female, and adolescent idiopathic scoliosis is more prominent in females than males and typically displays with a left lumbar curve associated with the right thoracic. The evolution of the Boston bracing system. The Boston bracing system provides low braces for most curves. Module changes over time have resulted in a size range of stock modules that will fit most patients except the extremely small or large. Others, because of their unique shape or bony prominences about the pelvis, need to have a custom form fabricated. This can be achieved through a model being taken of the patient or a series of measurements that are then matched with a model or transferred to a CAD program. The system has evolved over the years, and today more attention is paid to the sagittal plane. A 15-degree lumbar shape is now the default design. The concept and biomechanics of reducing the lordosis lie in more pelvic control and providing a solid base of support. In the thoracic area, a prokyphotic design is now incorporated. Having the trim line just superior to the apex of the patient's kyphosis may provide enough leverage to prevent them from developing a hypokyphosis over the top of the orthosis. Indications for the introduction of the Boston bracing system. Best scenario is a single curve with a thoracolumbar apex, the curve angle between 20 and 45 degrees. Apex of the curves between T7 and L1, if growth remains and if all other prognostic factors are favourable. The patient needs to be reassessed 6 to 12 months after bracing is commenced. Now we discuss Boston brace principles. You have standardized symmetric modules. You utilize a brace blueprint methodology. You control lumbar and pelvic flexion. Its brace system is active as well as passive in its correction. Provide relief opposite every force. And the pad pressure is at the apex and below the curve. Standardized symmetric modules. Standardized symmetric modules provide an inherent correction within the size range. It saves fabrication time, and this time is available for the design and modification of the orthosis. Boston brace blueprint. Boston brace blueprint. Why blueprint? The blueprint is a symmetrical way of analysing the curve and placing the appropriate corrective force vectors within the brace. The fitting process follows a logical thought-out process to focus on curve segments, not curve types, to focus on decompensation, trunk and pelvis, for pad placement and for brace trim lines. Lumbar and pelvic flexion. Lumbar and pelvic flexion provide better foundation for brace, reducing the slip and improving function, an inherent lumbar curve correction from module design, and flex lumbar spine, making it more available to pad correction. Active and passive correction. Active and passive correction. Areas of relief for opposite forces enable the correction forces and are based on Newtonian physics. Primary, the third law, every action has an equal and opposite reaction. The tissue can only tolerate so much force, so to maximise the force within a Boston brace, we need to reduce the reactionary forces as much as possible. Opposite every force there needs to be an area of relief. The most common error in designing a Boston brace is the lack of proper relief areas. Active exercise relates to a complete program that is designed individually for the patient. Posture in brace and out, as well as a complete stretching and strengthening program, is vital. Relief opposite every force. Relief opposite every force. Passive correction is enhanced to allow maximum function from applied vector forces. Active correction is facilitated by accommodating correction so that excess load is not applied to the skin surface. Pad pressure at the apex and below. Pad pressure at the apex and below. Empirical data has proven that better correction of the curve is achieved with the pad position below the apex of the curve as identified by the blueprint. Biomechanical and mathematical models confirmed this principle. This diagram demonstrates the principle of pad location within a Boston brace. In 1992, Vornsky and Schultz released a paper in which their computer model of thoracic scoliosis and applied brace forces suggested that biomechanically the most effective placement of forces is at the apex and below the apex of the curve. By applying these principles, you can transform a prefabricated symmetrical module into a customized orthosis designed specifically for an individual patient. We talk of three basic brace design types: lumbar brace, thoracolumbar brace, and thoracic brace. We can use any of these designs. The brace is defined by the highest pressure or acting force. The blueprint will dictate the height and side of the forces. Boston lumbar brace. In these braces, the lumbar pad is the highest component and is used for lumbar curves, thoracolumbar curves where the patient is decompensated to the convex side, or double curves with a flexible thoracic curve. Boston thoracolumbar brace. This is where the low thoracic pad is the highest component and is used for thoracolumbar curves where thoracic component is flexible, or lumbar curves where the patient is decompensated to the concave side. The Boston thoracic brace. This is where the axillary extension is the highest component and is used for thoracic curves, double curves, or thoraco curves where the thoracic component is not flexible. Full evaluation for a Boston brace is imperative. This encompasses clinical assessment, X-ray assessment, social and psychological assessment, and a blueprint design and assessment. Clinical assessment. Clinical assessment is a team approach. The prescribing clinician needs to fully understand the Boston brace system. The orthotist needs a full understanding of the guidelines for manufacture, as trim lines are guidelines to be interpreted, not instructions. Physio input has to be specific for individual rehab regimes in and out of the brace. These team workers have to work with each other. The family are the centre of the team. They are always the focus. Having a well-informed family is paramount to success. The clinicians need to be realistic in their discussions and to be as user-friendly as we can to achieve maximum compliance. As part of the orthotic assessment, the patient must be clinically evaluated from behind and the following factors identified. Checked for asymmetries of knee levels, trochanter levels, waist symmetry, scapular and shoulder. Undertake a forward bend test. Check for any paraspinal and rib humps. Check for the spinal flexibility and the presence of any hypokyphosis. All these surface landmarks need to be identified and if necessary marked, as they will be required for measurements of the module later. X-ray assessment. X-ray assessment needs to be done on the spine posterior, anterior and laterally. The Boston brace is based on symmetry. The goal is to obtain the maximum reduction of the Cobb angle, which is a measure of the curvature of the spine in degrees, and best overall balance, while not impeding on patient tolerance, so identification and determination of relevant Cobb angles is imperative for Boston brace manufacture. To measure the Cobb angle, one must first decide which vertebrae are the end vertebrae of the curved deformity, the vertebrae whose end plates are most tilted towards each other. Lines are then drawn along the end plates and the angle between the two lines where they intersect measured. A Cobb angle of 10 degrees is regarded as a minimum angulation to define scoliosis. Prior to commencing a Boston brace program for the treatment of idiopathic scoliosis, you need confirmation of the skeletal maturity. From X-rays, the risser sign can be identified. This is an indirect measure of skeletal maturity, whereby the degree of ossification of the iliac apophyses by X-ray evaluation is used to judge overall skeletal development. Mineralization of the iliac apophyses begins at the anterolateral crest and progresses immediately towards the spine. Data from X-ray assessment can be used to identify the likelihood of curve progression using the Lonstein nomogram. Two patients, both with 20-degree curves with different risser signs, have potentially highly significant different outcomes to possible curve progression. Social and psychological assessment. Social and psychological assessment. The patients and their support group are the most important part of the team. The success is not so much the actual brace, but the motivation and dedication of the patient. As clinicians, we need to share the same end goal. Then we can work backwards on how together we can obtain it. Let them know it's not easy. The brace itself will age. but that perseverance will help us obtain the stability into adulthood we desire. Daily schedule. Brace wear can be integrated. Activities and sports. The brace can be worn for chosen activities. Do they know other people with scoliosis? Are they aware, or do they want contact with support groups? Feelings about the orthosis. How do they feel? They have to buy into the system and wear the brace for it to be a success. Blueprint design and assessment. Boston Brace blueprint. Why do we blueprint? As previously stated, the unique Boston Brace system blueprint process allows the clinician to focus on individual curve segments, not curve types, to focus on decompression at the trunk to the pelvis, to identify correct pad placement, and to determine the brace trim lines. The following slides provide an overview to blueprinting. The design of the brace is determined by the type of curve being treated. It could be a lumbar curve, a thoracolumbar curve, a thoracic curve, or a combination of these curves, i.e. lumbar and thoracic. The X-rays in this slide show a left lumbar curve, a right thoracic curve, and a double curve. The X-ray is evaluated, and this becomes a blueprint for the brace design. In this case, the brace will be designed to apply a force to correct the lumbar curve and a force to correct the thoracic curve. The X-ray tells us where we need to apply the corrective forces. For this curve pattern, these are the areas that we need to apply the force to. The forces will be applied at the left trochanter, left lumbar area, right thoracic area, and at the left axilla. The brace is going to have a left trochanter extension, a left lumbar pad, a right thoracic extension, and a left axilla extension. Using the X-ray, we can calculate the length and position of the lumbar pad and the length of the thoracic extension. The waist rolls of the brace locate between the vertebrae of L2 and L3. We can now measure the distance from the waist to the rib at the apex of the curve, which will give us the length of the thoracic extension. Digital X-rays make this part of the process much easier, as we can stroll across the X-ray from one point to another point, and the software calculates the distance for you. Patient measurement and module selection. You now need to identify your Boston Brace module, and using measurements and your blueprint to go from this to this, the completed orthosis. Fabrication options. There are two options for Boston Brace manufacture. Option 1, the customer orders the module and then fabricates the orthosis using measurements and blueprint. Option 2, the customer supplies Allard Support UK full universal spinal measurement chart and X-rays, and the brace will be fabricated to first fit stage and will be supplied with corrective pads shaped but loose. Module measurement. To determine the module size, first take the following measurements and then refer to the product chart. Measure circumferences at the trochanter, the waist, take this measurement very tight, and the xiphoid. There are a number of other anatomical measurements previously identified which will help establish the brace trim lines. These measurements should be taken by the orthotist at the same time they measure the patient for the module, and marked on the Boston Brace spinal measurement form. Anteriorly, circumference and width at the axilla, nipple line, xiphoid, lower rib, waist, this must be measured tightly, and the trochanter. The distance from the waistline of the sternal notch, xiphoid, symphysis pubis, and the width at the asis. Posteriorly, you need to measure the distance from the waist of the spinal scapula, the axilla, the inferior angle of the scapula, and the gluteal fold. The manufacture of Boston Brace. The blueprint measures from the X-ray are used in conjunction with the landmark measurements recorded on the spinal order form. They are then used to enable the identification of the trim lines and the final design of the module to become a completed Boston Brace scoliosis brace. The main stages in the brace fabrication process are highlighted here. Initially, first we mark a vertical center line on the module. the level at the waist rolls between L2 and L3, along with the distance from the waist to the xiphoid. Other anterior and posterior points are identified from both the blueprint and the spinal measurement chart. The points are joined up and any windows highlighted and trimmed out first before the edges are removed to produce an unfinished shell. This is what the brace should look like after it has been machined. All the edges have been buffed and polished ready for fitting. As a rule, we position the buckles on the side of the brace with a pad, i.e. left trochanter pad buckle on left, left lumbar pad buckle on left, and right thoracic pad buckle on right, and we attach the straps. Most of our braces have an elasticated gusset attached over the window. This gives a better transition from brace to patient, and it also covers the ribs that protrude through the window. The gusset is glued to the brace and then welded with a 4mm polypropylene strip around the edge of the gusset and the brace. The final component of the brace is the pads. These are the trochanter pads. These come in two sizes, small and large, and are trimmed to suit each brace. This is a standard trochanter pad on the left and the pad trimmed to fit the brace on the right. This is what the pad will look like inside the brace. Lumbar pads come in four sizes, two small left and right, and two large left and right. This is a standard lumbar pad on the left and the trim lumbar pad on the right. This is what the lumbar pad will look like when it is fitted into the brace. The thoracic pad, like the lumbar pad, comes in four sizes: small left and right, large left and right. The standard thoracic pad on the left and the pad trimmed to fit the brace is shown on the right. And this is what the thoracic pad will look like when fitted into the brace. Brace checkout. You now have a Boston brace that fits your patient, so the next phase is to check the fit and function of the orthosis. The following points need to be checked: the overall posture, hypokyphosis, trim lines, and check how they relate to the blueprint and design of the brace. Overall posture. The patient should be able to doff and don the brace and move from a sitting to a standing position unrestricted. On standing, an improved upright neutral stance should be visible. On initial trial, the straps will not be fully tensioned, so mark where they need to go, and they can be tightened as the patient becomes acclimatized to the fit. Hypokyphosis. The spine has a normal kyphotic angle of approximately 30 degrees. Hypokyphosis in adult idiopathic scoliosis is independent of the pelvic parameters and could be described as a structural parameter characteristic of the scoliotic deformity. If this is exacerbated by the introduction of a Boston brace, you need to be aware of the possibility of tight hamstrings that will require localized physiotherapy, and or an extension of the posterior superior extensions or rabbit ears, otherwise referred to as a hypokyphosis modification. Anterior trim lines, superior, at the level of the xiphoid process, in hypokyphotic patients 2 cm below the xiphoid. Anterior trim lines, inferior, 1 cm clearance at the anterior thigh with the hips flexed at 90 degrees. Flow the trim lines down to cover the symphysis pubis. Posterior trim lines, superior, for normal kyphosis 2 cm inferior to the inferior angle of the scapula. For hypokyphosis, at the upper margin of the spine of the scapula. Posterior trim lines, inferior. You need to provide a 1 to 2 cm clearance from the chair when sitting with the hips flexed at 90 degrees. Lateral trim lines, superior. These will be dictated by the blueprint. Lateral trim lines, inferior. The trochanter side, same level as the posterior inferior trim lines, always covering the trochanter. Opposite the trochanter extension, 2 cm clearance over the trochanter. The bracing program. The brace needs to be worn between 20 and 23 hours a day. This can be reduced to 18 to 23 hours after 6 to 9 months. The brace should be weaned out after skeletal maturity, and the patient can continue all sports, i.e. swimming, up to 1 hour a day out of the brace. There should be a 2-week break-in period, then an in-brace X-ray to follow up 6 weeks after brace applied. The patient needs to visit every 6 months for a review, X-ray out of brace every 12 months. Ongoing physiotherapy is imperative, and the brace will need to be replaced with growth and development and to be weaned out at skeletal maturity. Possible issues. If no blueprint has been taken, it could well result in an ill-fitting and non-functional brace, causing rubbing and discomfort. A poor module choice will be too loose and effective or too tight and non-functional. Poor module fit will reduce compliance. With the waist too loose, you'll have reduced correction at lumbar level and at all levels. And if not enough relief has been provided, skin breakdown can well be an issue. What to look for in a Boston brace. A 50% decrease of the in-brace cob angle. If less than 50%, is it a poor brace or does the patient have a stiff curve? This is when you really need to know bracing. Boston braces can be most effective with a good clinical team that results in a well-made brace, when monitored well, when the clinician is familiar with the Boston brace system, when used full time, and even in larger curves. Bracing medical evidence. There are often questions raised when discussing the use of bracing when treating adolescent idiopathic scoliosis. Does it work? How effective is it? And should the brace be worn full or part-time? In 1995, the Scoliosis Research Society initiated a study to investigate the effectiveness of bracing as a treatment for adolescent idiopathic scoliosis. Previous studies of full-time bracing had shown that it stopped about 80% of curves. However, they were uncontrolled, with no simultaneous groups of untreated or unbraced patients for comparison. There existed some doubt the bracing actually worked. Was it any better than natural history? The multi-centre study was conducted by Dr. Alf Nackimson, himself a skeptic. Patients of the same age, curve pattern and curve severity were divided into 2 groups, one treated with bracing, the other not. The results showed that bracing was effective compared to natural history, displaying a 74% success rate. Nearly 2 decades later, in 2013, Weinstein presented a paper, The Effects of Bracing in Adolescents with Idiopathic Scoliosis. This revisited the question, does bracing work? It was a multi-centre study in both United States and Canada over 25 locations. 242 patients were observed, and the treatment consisted of bracing or observation only. The bracing group wore the orthosis for 18 hours a day, and failure was deemed at progression of a curve above 50 degrees. The trial was stopped early in January 2013 after finding that bracing significantly reduced the risk of curve progression. This study from 2009 evaluated the long-term results after Boston brace treatment in adolescent idiopathic scoliosis by using validated health-related quality of life measures. Mean time was 19.2 years after bracing, with a global back status of excellent or good in 81%, and long-term results were satisfactory in the majority of patients treated with the Boston brace system. Brace wear control of curve progression in adolescent idiopathic scoliosis was reviewed by the Texas Scottish Rite paper released in 2010. This actually confirmed that the Boston brace is effective in controlling curve progression in patients with adolescent idiopathic scoliosis when it is worn more than 12 hours a day. The effectiveness of the Boston brace in the treatment of large curves in adolescent idiopathic scoliosis was published by Mitchell, Smith and Thompson-Newington in February 1997. The study covered 54 patients with curves varying between 35 and 52 degrees. Many showed significant improvements, with full-time brace use doing much better than part-time. There is conclusive evidence available for the validation and management of adolescent idiopathic scoliosis with the Boston Brace system. Long-term results? Yes. Curve control? Yes. Effects of bracing? Yes. Full-time or part-time use? Yes. Large curves? Yes. So here we are, the summary slide you've been looking for. Over the last 35 minutes we have reviewed the history and evolution of the Boston bracing system, identified its principles, discussed the variants, explained both brace evaluation and brace checkout, and we have reviewed the evidence that confirms the effectiveness of the Boston brace system in the treatment of adolescent idiopathic scoliosis. If you have any questions concerning anything in the content of this program, please do not hesitate to contact either Customer Services at Allard Support UK, myself Mike Vaughan, or any member of the Allard Support UK sales team. We would love to hear from you, and we are here to help. Thank you.